This is the In Focus podcast from The Hindu.
Hello and welcome to another edition of the In Focus podcast. I'm your host, G. Sampath. The delay in conducting the 2021 census seems to have sparked a data crisis in India, with major implications for the social sector and especially health policy, planning, and management. This crisis, according to commentators, has been worsened by the government's reluctance in making available even official data, making public official data over concerns that they might show the government in an unflattering light. In the context of public health, the census is important because it forms the basis for national and state health service. So how are the country's policymakers and social scientists managing with 2011 census data in 2024? What are the problems seen in the implementation of government welfare schemes such as PMJAY, Pradhan Mantri Jan Arogya Yojana, due to an unavailability of accurate and up-to-date data? And what's the status today with regard to transparency in the collection, scrutiny, and publication of data that's central to the public health discourse? We discuss all these questions in this episode of In Focus, and we have with us Professor T. Sundararaman, a public health expert and former executive director of National Health Systems Resource Center, and he has also been Dean and Professor, School of Health System Studies at TISS, Mumbai. Dr. Sundararaman, thank you so much for joining us and welcome to In Focus.
Thank you.
Sir, to start with, I was wondering if you can explain for us what are basically the problems caused by the delay in the census exercise in the context specifically of public health.
So we must understand that public health is population health. It is the health of a population as different from a clinical health where a single patient is being seen. The main source of data on population by definition is the census. And without a census, we do not have a population database at all. What we are using now is extrapolations from the 2011 census, where we are assuming a birth rate, we are assuming a death rate, we are assuming changes in migration, which all of them are based on assumptions which are seriously outdated at the best of times. Now, there are two sorts of problems that arise from this. One, for all public health calculations, whether it's a morbidity rate, whether it is a demographic information, whether it is epidemiological information, you need denominators. Denominators come from of the census more often than anything else, because you are basically saying that we are doing a sample household survey, and that sampling is based upon our recent census data, which gives you village data. So if I take a sample of villages, then what population that sample of villages represents of the total population is the demographic characteristic. How do I adjust to make sure that the population characteristics of the sample match with the characteristics of the overall population? All these calculations rest upon these denominators, rest upon the population census. So the census is the basic frame of reference, that universe, as you may, from which the sample is drawn. And if you haven't got a definition of the universe, then very serious sampling surveys on the basis of which so much of all demographic, epidemiological, healthcare data is there is missing. The other is data that the census itself yields. So the first was that for all health data, population-based data, this is the baseline, the reference. But the other is that there are things like, for example, the number of doctors employed, the number of about mortality in the preceding period. There is a whole number of other data that comes directly from the census and either collaborative of other sources or independently of other sources on that. And not having that information on place is important. The age pyramids, the demographic age pyramids, what proportion of the population is above the age of 60, for example. What proportion of the population is what is mortality rates above the age of 60? What is mortality rate in the 15 to 45 age group? These are sort of information that come necessarily from the census. They vary very highly across districts, and that variance is also comes from the census. So, in some sense, public health as a science, as a measurement based science, is crippled by the lack of a proper census data and thing. That, I think, is the big problem of the day. We are managing with extrapolations of 2000 level data, but as the time extends, the difference between the extrapolated sum and the actual thing varies. So when international agencies provide information based on extrapolations, we contest it seriously. But when we do the same, then there is a definite problem with that. And I think that we should understand that without censuses, meaningful public health science is really handicapped.
Right. Thank you so much, Dr. Sundaraman. That was beautifully, I think, explained actually the problems with managing with an outdated census. I mean, the whole question of extrapolations, assumptions, and distorted denominators for sample service. I think these are all very, very central issues, and they have a tendency when they're crippling public health science, as you pointed out. Now, the next census it is expected to be conducted later this year, and it is likely to be an electronic one. What are your thoughts on an electronic census that's never been done before in India? Is it a good idea? Do other countries do this as well?
Well, see, digitization per se is not a problem. The matter is of what it is done. After all, what is written down manually can be directly entered into a computer-based terminal. It prevents manual data entry with its problems later. That I think is useful to at least it serves or reduces in one level of problems. What is a problem in very often the forms that digitization takes over here is that the intermediate levels of control, validation, cross-checking should remain enabled. If the database goes all into a central database without the ability of local supervisors to launch sample checks, all sample census surveys have random checking of the census, different samples are taken to see whether it's being adequately done. These systems of validation need to be preserved. And one needs to be able to see whether at the local level they are able to verify the validity of that. That I think is the most important thing. And it also gives confidence in the census that it has been validated at different levels. It's not inherent that electronic census will prevent such validation. It need not. But very often these systems seem to assume that a central eye willing to drill down, as they say, and see every machine is a more reliable option. It is not, because the central eye is too far removed from each village and each census enumerator, and it requires intermediate levels of supervision, and they require to be enabled to be able to do their supervision adequately. So that is the challenge. So I wouldn't, I would be more worried about what is the architecture, what is the certain operational plan of the electronic census, not about entry into a digital platform. That is all right.
There were some reports that people would log in and give their information on their own rather than census people going and going with their file and taking.
That is absolutely, I mean, on the borders on the absurd. This would mean that most people who would find it very difficult to digitally do so would have some other person who is not qualified, who is not independent, who is not neutral entering it on their behalf, leads to all sorts of bias. There is a requirement when an enumerator does to cross-question certain information to check even as he goes along on the validity, who has given, what is their ability to respond. All these elements cannot be and should not be removed by asking in if the understanding is of people self-reporting onto a census platform. It's a bad idea. It's a bad idea. It needs the transaction with an enumerator is needed for clarity, even for the person filling in. And about the nature of the question, about the nature of the response, and as you go on to be able to ensure that it is done. It is not more reliable, it will be less reliable because people will need to take help. But instead of a trained person known to be neutral, entering that area to provide help, the help will likely to be people with their own uh, levels of knowledge, capacity, and prejudices. So I don't think the proper format of a census enumerator and their supervision should not be compromised by an electronic census.
Right. So an electronic or a self-reporting census is a bad idea, and there has to be necessarily a transaction with an enumerator. That's a good point. Thank you for
Yes.
that,
That is
Professor.
what I'm trying to say, that electronic and self-reported, electronic and poorly supervised need not go together. Entry can be in a digital platform, but it must be capable of verification in the immediate and at the intermediate levels. And self-reporting without trained enumerators but conducting the interviews is a bad idea.
Right. No, other than the census, we have a number of other data collection and survey exercises which are undertaken at multiple levels. So what has been happening with those exercises? So can you please give a brief overview of the other surveys and stuff?
The single biggest other exercise is the demographic health surveys in India called the National Family Health Survey, which itself amalgamated two types of surveys. It's a major source of information. That information came under what I would say rather unfair criticism in the last round. And that criticism emanated from the fact that some of the results that it showed seem to underplay or undermine the government claims in that regard. The one that was most discussed was the claims on open defecation elimination. Clearly, the open defecation elimination had not happened. I mean, the government claims that it had succeeded were shown to be false. But my own sense of it was that even the NFHS claims was too good to be true, but given anecdotal evidence. But it's still the best source of information available. But what happened was a act of shooting the messenger. The person who was in charge of it was subject to a lot of hostile scrutiny. A number of cases for disciplinary action on other grounds were raked up against him. And on his offering resignation, all those cases were withdrawn. So, in some sense, the NFHS now has handed over to a leadership whose autonomy from the government, whose reliability is compromised, not because they have done anything as yet, but because of the terms in which the predecessor was treated. But still, the NFHS remains one of the most important robust source, and the next round is due and is happening. And that's, I think, somewhat good news because it's the second major source of data. What has been unraveled is the national sample surveys, which in the consumer expenditure survey brought a whole lot of health expenditure into play. And in its landmark morbidity and cost of care surveys was our major source on morbidity data and our major source related to the health expenditures, choice of providers. These information is seriously compromised. Employment surveys were to give us data regarding the number of doctors, nurses who are employed with their different qualifications. Those also are compromised. So I think what we now have is a situation that a whole lot of data that is related to public health that used to come from the National Sample Survey, that entire set of data now, we have a gap of more than 5 to 6 years. The last was in 2017-18. And in between, we have had a major health episode that occurred at the demographic level, the COVID-19 pandemic. And given the high degrees of mortality associated with it, the high degrees of, shall we say, population movements and migrations are associated with it. It not only changes the baseline, it changes the morbidity features also. And we don't have any measure of what is happening after that. I think this is something that is most worrying. Other than this, we need to know, I don't know enough, what has happened to the longitudinal aging surveillance, the LASI surveys, what has happened to other surveys that were intermittently done on this. I think the surveys on non-communicable diseases and risk factors is due for repetition. So there are other surveys that are population-based surveys that need to be done. I'm not personally aware what it is done, but I haven't heard of it being done with the frequency it was promised, and that's worrying on that. There is one more important source of data that is delayed, and that's very worrying, is the sample registration survey. This is actually part of regular registration of deaths, but a sample of that is verified, and recently it was verified through verbal autopsies to provide information on death registration and a preliminary understanding of cause of death with a high reliability on age and gender composition of deaths. That's not happened. I mean, a very unusual first time delay that it used to come out annually. Now I think it is 2 to 3 years due on that. But along with this, the thing is also there were regular reports on the cause of death based upon aggregation of 3 to 4 years. That hasn't come out. So that's the registration of deaths data based on the registrar of births and deaths. That also is not currently available and behind time, and we don't have enough information. These were supposed to be improved in quality and brought into the public domain and be regularized. That was the direction in which we are moving. The periodicity is faster, and the time interval between collection of data and release is cut down to less than a year. It was 2 to 3 years. Now, all that seems to also have gone into the back burner on that. So I think there's been a serious crippling of nearly all the sources of data that are important in public health.
Right, and where do we stand when it comes to measuring things like the prevalence of various diseases like cancer, diabetes, child mortality? I mean, how are we doing with regard to data availability on these core aspects? Because some NGOs also collect data, I think, not just the government. Do we have any? Are we doing any better here?
So child mortality is the sample registration survey. That's our main source of data, and NFHS. That still has some degree of reliability, except that the SRS survey, the most recent two surveys are due, and delays are always worrying under this context. So child mortality is on one plane. But cancer, diabetes, look, we never had very reliable data on those. We never had it. It's not that we had an earlier data, but we had data sources from which we could derive recently, and NFHS was one reliable source of data. It's not really geared to this, but it was doing some data. There was an NCD prevalence survey that was done, which was supposed to be repeated. So we have not seen an adequate, even before the architecture on this was weak. So either we used NSS morbidity data, which the 71st round and 75th round was the most recent, but that source has its limitations. And then we used specific data, but not, these are not population-based data. These are study-based data, which became very context-specific, and we need to extrapolate from it. From cancer, we also have the cancer registry as a source of data. But again, we can say a lot of things within the sample. Okay, we can say what is the relative prevalence of different types of cancers, but it is within the sample. How representative this sample is of all cancers, we really don't know. And because we know that the cancer registries capture only a part of the cancers that are prevalent in the country. And that, I think, is an important. So morbidity data on non-communicable diseases, even in communicable diseases, is the quality of data that is of policy relevance. We do get a lot of data from the health management information systems of public services on diseases. But here, public services provide to only about 30% to 50% of all morbidities. The rest of it happens in the private sector. And there is no systematic collection of morbidity and mortality profile in the private sector that is fed into the health management information system of the public sector. So the public sector is an arbitrary, as different from random. It's an arbitrary selection of cases from a universe, and we don't know whether it is the true representation of the situation in the entire population. However, uh, uh, we can use it, and skilled public health experts are able to make use of this data for interesting extrapolations which are being used. But this is a poor substitute for having population based data, which is possible now. We have the means to do so, but the will to do so is what really seems to be lacking.
Right. Thank you for that, Professor Sundaraman. I mean, I think it's very clear now population data is of particular relevance and criticality for public health as a science and for public health policy planning. Now, you mentioned public services here just now. The NDA government, the current regime, has adopted a three-pronged approach from what we can make out towards public health. I mean, one is health insurance for the poor under PMJ. The second is opening of generic medicine stores, and thirdly, expanding the network of hospitals by opening more medical colleges and tertiary care centers. Lots of different aims in different parts of the country. So, do we have enough data now to assess the impact of this three-pronged strategy over the past decade or so?
Reliable data, the last reliable source of data is the 71st round of the NSSO.
That is which year?
That is 2013-14, I think. Yeah, 2014. The 75th round took place at 2017-18. It also is the same design. It gives some information, but for technical reasons, its reliability has been questioned. However, saying so, after 2017-18, there is nothing. And remember that after 2017-18, there has been major expansions in private sector presence. There has been major health changes in the population. There has been major expansion of public health programs. So we really don't know what is the situation on this. But that being said, the design of a properly implemented NSS survey of the 71st round model was very good. It's very robust. And we have a data series of that goes back to the 80s or 70s, and it's a very good source of data. So we know how it is to be done. We have been doing it very reliably. And when you say what is the impact of health insurance schemes, of PMJAY, of generic medicine stores, of expanding the network of hospitals, of opening more AIIMS, every one of these questions could have been answered very adequately by the use of this same approach that the 71st round of NSSO used. Remember that these rounds are paralleled while there is a central pool of data. Every state planning and measurement division department does a parallel survey, and they have a larger pool of data done on the same questionnaire and methodology. Very few states actually analyze it. But with that data, you can actually have a granular information down even to the district level. Otherwise, one limitation of the NSSO data is you have state level information. Your reliability when it goes down to district and sub districts are low. But along with the state survey, it has enough power, sampling power to be able to comment on that. So these questions, it's not whether we are, at that time, we didn't have a publicly health funded insurance program when we had the earlier rounds of health surveys, cost of care and morbidity surveys. That time there were no major publicly health insurance programs, and there were very few insurance programs that the private sector reach was less than 1%. Now we claim that the ESI alone reaches 10%. Publicly funded insurance programs reach 40 to 50%. This should show up very much in the surveys. And the last surveys did not show it up. It actually showed that the achievement was 1/10 of the projected achievement and claims. So it's difficult to say what motivates governments to do what they do. But the fact is that this information was available, and now that these schemes have been rolled out in full, they are no longer available to be able to tell such data. Provider information from insurance companies are all prejudiced by the fact that they always can tell something reliable about those who came to the hospital, but they never can tell about those who ought to have come but did not come. That's something that a population-based survey can only tell, and a community-based survey, a household sample can tell. That is an important issue.
Right. So we did have the kind of survey infrastructure to sort of basically answer this question of how these three-pronged approach of the government, PMJ, medicine stores, and network of hospitals, how effective they have been, but we have not been using that infrastructure of surveys and data collection exercises to find out. So, and as you pointed out, the last such survey indicated that these initiatives of the government were only effective 1/10 of what were the projected aims, and after this there was no other survey. So we don't really know, because this is interesting also because I mean, the regime does make a lot of claims about its various schemes, including PMJ, but we don't seem to have adequate amount of data to sort of assess it independently, and to sort of talk about it in an informed way. So to one final question, sir, before I let you go. So how do we resolve this data crisis? Now, if we are sort of saying that we have come so far in the last 10 years, 15 years, or 20 years, one way to measure progress is data. How do we measure progress or the lack of progress in public health without data? Should the bodies that collect data be made, for instance, I'm just thinking aloud here, should they be made independent of the union government's control and maybe made answerable to state governments instead? Should state level data collection entities be given more autonomy? How do we go forward from here to resolve this crisis?
First, I agree that state governments should build up robust systems of data information collection and control for their use. They already have systems which are piggybacked with the central government, but where necessary, they can do it on their own. But even where they need to do it in synergy, they can do that. But the union government has obligations. They have obligations under the international treaties they have signed, whether it is emergency care preparedness, or whether it is emergency health preparedness, or whether it is things like progress towards sustainable development goals, whether it is the fulfillment of the international covenant of social and economic rights, to be able to measure progress and present data. So I don't think that the union government is under international and its own national obligations to be on top of health information data. The danger is that instead of actually building systems that allow states autonomous control, the union government almost asks for the data entry to be directly onto its portals, which means that the processing and analysis of data becomes sometimes non-transparently under union government control. This is not necessary, but it can happen. So I think in architecture, where one, the union government is responsible, has bodies that have a professional autonomy from the central government and a government of the day. Like, remember, we do have such an institution. No? The last director of it was really hounded out. This is the International Institute of Population Sciences in Mumbai. It's meant exclusively for this. It has a very good record, and it did not have sufficient autonomy. It acts directly under the Ministry of Health. It should have been given more autonomy and strengthened. But in a sense, past governments respected their professional autonomy and gave them a sort of operational autonomy. So when the survey was on, the government of the day may have some priorities on some questions it wanted to be asked or not asked, but it would not get into the actual design of the survey or the analysis or the results. Whatever the results they give, well, the government can talk their way out of it, but they could not touch the results. That degree of professional autonomy was there. What you need is now a more legislated legal autonomy, and plus a issue that they are provided with a professional capacity to do this service regularly, and state governments should develop their own capacity. I don't think this should be placed one against the other. But I have another point to make. I think that we need not be very insistent on a single window of truth, a common phrase used in government, that they see the multiple data reports coming from different sources to not match each other very closely, sometimes be confusing. This is not to be seen as a problem. Each of them represent ways of sampling, represent ways of the questions were asked, structures, and triangulating the information from different sources gives a greater reliability than relying on any one source as an exclusionary window of truth. This is a point that I'm making. If you're going to preserve the truth, let states provide their data, let the union government do its data, let independent research institutes do their data, and let them come up with analysis. Let each one defend their analysis. And in the discussion between them, you will have a better sense of the truth than giving any person, even an autonomous body, absolute charge over what is truth or not is truth. And so there are attempts to quell any other source of independent data, which are equally very dangerous. I don't think that we should allow data to be controlled by any one authority, autonomous or otherwise.
Right. So, I mean, that there need not be a single window of truth. I mean, we need to have multiple sources of data
Much of
collection.
this unit data, much of the unit data, suitably anonymized, must always be on the public domain. This must be a legal requirement where data of household surveys collected on public financing are done, even if it's through a research institute, a private research institute. If it is public financing, it's public data, and this data, unit data, suitably anonymized should be. That means, for example, all the data of the health insurance companies that work for PMJAY or health insurance programs, even that data should be on the public domain as anonymized unit data, because that means you won't say which hospital, which patient, but in aggregated numbers, you will know the number of cancer patients under insurance, the number of this under insurance. And I think that is extremely important to
So right now,
whatever
this
the
data
number
is
of
not
patients.
made public. Right now, this data is
No,
not made
it's
public.
not made public. Not made public. It's not made public. And even right to information use has not made it public. Sometimes some sets of data are made public to some researchers, often of international agencies, but not public to even the research agencies that are operating within the country, Indian funded university based research agencies.
Right. More autonomy, more transparency, and more access to the public. Data should come into the public domain in a unit sense. Thank
So
you so
the
much.
census data and NFHS data has traditionally been on the public domain. But I'm talking of other data like insurance data. I'm talking of data like the NSSO data was in the public domain. These earlier surveys, this was part of a very well thought out democratic polity, and therefore they were on the public domain. But some of these other surveys which are now happening now, you don't, from like say insurance sources or from the health management information systems. These also have important data on the public domain. If they are there, even their validity, even their reliability, their data fidelity will improve because they will be challenged, and that helps. They will be challenged, they will be used, and the use of information, the discussion over data itself improves the quality of data.
Right. Thank you so much, Professor Sundararaman. It was an absolute pleasure talking to you. Very insightful observations and comments on this entire data scenario in India. There are issues with delays, there are issues with transparency, there are issues with access. All three are sort of painting a very grim picture. Hopefully, there will be a greater public discussion about this crisis and there will be some kind of progress made. Thank you so much once again. Pleasure talking to you.
In Focus will be back soon with analysis of the biggest news issues. In the meantime, you can find our podcast on Spotify, Apple Podcasts, Stitcher, and other platforms. Just search for In Focus by The Hindu. We'll see you soon.